Well, hello and welcome back to another episode of Bostic Health in the Wild here at Health 2025 in Las Vegas. I'm thrilled to have Matthew Holt with me, who is the leader at the Healthcare Blog, a blog I follow, and I appreciate you being here, Matthew.
Bradley, thank you very much. I count my readers, on the hands, about 2 hands. So I want to keep you in good health. So you keep coming back. I have a little joke. We used to have a podcast that actually wasn't that well followed by the TCB gang. And one of my colleagues on the TCB gang, there were 6 of us, was at a conference. And a guy in the row behind him said, "Oh, I recognize your voice." And I said, "Yeah," like, "Oh, famous." And he said, "Yeah, my father used to listen to the podcast, but then he died." And when they told me the story, I said, we don't have enough subscribers. We don't have enough listeners and subscribers to lose them.
So we got to keep them alive in order to keep the podcast going.
Appreciate you paying attention.
Absolutely. Well, my Bostic Health was really born out of my penchant for building companies in the health tech world and investing in companies in this world. When we first started this, I wasn't sure if anybody would listen to it. My mom passed away of cancer 25 years ago, so I knew she wouldn't be listening to it. And unfortunately, but that was a big thing that inspired me to get into healthcare. And lo and behold, there is a really interested audience out there that wants to know how innovation is transforming our broken healthcare system. And clearly, with your background with Health 2.0 and the healthcare blog, this is an area that you're focused on. And I think you said you have 2 easy steps. Oh, no, 2 steps, not necessarily easy, to fix healthcare.
So the preamble to this is, I've been in this for a long time. I came to America in 1989. By the middle of 1990, by some fluke of literal placement of where I sat in a lecture hall once, I ended up doing some work on healthcare. I got really into the healthcare system. And then by the mid-90s, I'm now a British guy with an American healthcare problem. And I go through waves. Sometimes I'm optimistic that we can fix stuff. Sometimes I think, oh, this great new technology is going to fix everything. Sometimes I think the political winds are lining up and we're going to do the sensible thing. But we know the American healthcare system has massive complexity, massive differences in payers, a incumbent industry which has completely snowballed the payers at the consumers, makes a ton of money for what it provides, which is hideously complex. There are some great parts across American healthcare, but in general, on average, it's a terrible system that sucks and costs 50 to 80% more than any other industrialized nation. Plus, it puts the consumers, the American people, in this horrible position where they don't know where their insurance is coming from year to year, where they may have to go and buy on the public market with the chaos that you're seeing right now for people who may or may not be buying on the exchanges. If you lose your job, you can go on Cobra and you suddenly realize you're paying $3,000 or $4,000 a month for your family's insurance. And there is a lot of anxiety and fear just from that issue. And then even then, when you get insurance, it doesn't mean you actually get good access to care. And yet we lead the league in very expensive procedures in very, very profitable large institutions, many of which are non-profits sitting on hedge funds, bigger than hedge fund style reserves, which they treat like hedge funds, and by the way, pay their CEOs like hedge fund managers. So many issues, so many problems. I like to pick on UPMC, which is a massive system in Western Pennsylvania, as you know. And the reason I pick on them is actually that they're the good guys. They actually released their 990, their non-profit tax status report. And they put in their 990 how their top 200 people get paid. So I'll give you 2 minor sound bites on that. The first one is there is also a baseball team in Pittsburgh Pirates. The CEO of UPMC Medical Center system gets paid more than the most expensive player on the Pittsburgh Pirates baseball team. And the top 25 employees cumulatively in the Pittsburgh UPMC get paid more than the 25 players on the payroll of the Pittsburgh Pirates. And I will give you a quiz question. How many people on the UPMC payroll make more than $500,000 a year, which is a pretty damn good salary in Pittsburgh? Give me a guess.
100.
You're pretty good. 117. I don't know what the 117th person does to deserve $500,000 a year, but there is a very well compensated set of people all across American healthcare, in non-profits, for-profits, elsewhere, all of whom are doing very comfortably out of the system that we set up. So I'm at this stage of my life, I'm now fuming, I'm pissed off, and I have no fucks left to give about who I piss off about this. So that's the kind of backdrop to where we are. Oh, by the way, they lose money and they bought themselves a corporate jet recently. And UPMC is the only one I pick on because there are many other big hospital systems who hide their 990s.
On the upside, they're transparent.
They are more transparent than many others. And, you can go down the list, you'll see some of the big players who are on the stage here at health, and it goes down the road. We have private equity companies making bank out of both healthcare IT companies and also healthcare providers. We have, drug companies charging the highest prices in the world for their drugs by a factor of 3 to 5, and in some cases, many more times than that. Mark Cuban was on stage here ranting about it. He's got the heft to try to do something about it. All I can do is shout from the sidelines. All right. You asked my two solutions. Two solutions I think are relatively simple, but very, very hard to implement. The first solution is that we do a terrible job in primary care. Somewhere between 30 and 50% of Americans have no primary care doctor, no access to primary care. You want to try to get to a primary care doctor, you may be waiting 4 to 8 to many more weeks in most parts of America. Every policy one knows that if you have regular primary care, you do preventative care, you keep people with chronic disease in check for their diabetes, for their high blood pressure, for their high cholesterol. You do the stuff that we know and have known for 30 years how to manage that stuff with very cheap drugs and check-ins and behavior modification. You will reduce all the complications that drive up healthcare costs and that stuff. We are just completely crap at getting it done.
Because if you don't have a primary care physician, then the pathway is there's some catastrophically bad healthcare thing that happens and you end up in the emergency room.
Precisely.
And then there was no opportunity to get ahead of that. Versus if you have a primary care doc,
exactly,
they should be helping you navigate such that you don't have as many or as soon of these kinds of catastrophic issues.
Okay. And again, plus, right? Most primary care docs now are employed by health systems who view them as a feeder into the expensive stuff. And the health systems actually lose money, substantial amounts of money, sometimes $200,000 a year per employed primary care doc. And they are putting massive pressure to get people churned through.
Because they're basically routing into high margin services.
Exactly.
And they're like the lead qualifier.
Exactly. And they have a term for people who go to the primary care doctor and don't end up in their system, which is called leakage. I don't know if patients are aware of this, but that means you didn't show up. You were in the primary, you were in their system, and yet you went somewhere else to procedure. Every hospital that's either here or at the HA conference or anywhere else has somebody who's really concerned about that leakage number is and can I drive more people to our system? And that is good for the economics of that hospital and terrible for America. So, the incentives are completely screwed up. So here's what I think we should do. We have a small group of concierge primary care doctors who get paid money, usually by consumers, to actually have half an hour-long visits to look after the whole patient and to manage them. And those patients, there's arguments back and forth about the real numbers, but it looks like, to the untrained eye and to some reporting from others, that those doctors save about 30-odd% in downstream costs. It just costs about double primary care. We spend roughly $13,000 per human in America on all of their care. And if you save 30% of that, you're saving roughly $4,000. We spend now roughly, on average, $1,000 per person on primary care. And then a lot of this stuff ends up in the emergency room or ends up, in urgent care or somewhere else that's more expensive because those people couldn't access primary care. Here's my solution. You give all of us a voucher on our head. Give everybody a voucher on the head from the government. It's $2,000. You give every primary care doctor, nurse practitioner, and converted primary care doctors who currently are internal medicine doctors, cardiologists, OBGYNs, pediatricians, whatever. Say we are going to establish 600,000 primary care docs in various organizations. Could be solo, could be working in groups, could be doing whatever. And each doctor is going to get 600 patients, $2,000 per patient. That's $1.2 million. Those primary care doctors can now pay themselves $500,000 to $600,000, which is double roughly what they make now, and that's the same number roughly that specialists pay. Roughly. all the people in medical school who wanted to be primary care doctors, but look at their medical school debt and go, crap, I can't pay that off because I'm only going to make 200 grand a year as a primary care doctor, but I'll make 600 grand a year as a surgeon or a radiologist or whatever the number is. Can now go, okay, I can become a primary care doc. Now, you can vary this. If it's in an inner city or a rural area, you can make the number higher per head. If they're working with geriatric populations, you can make the number of people they have to serve lower, and you can make the payment higher. You can play with this. There can be risk adjustment. A bunch of stuff that the wants to do this. But that gives you a well-paid primary care doctor, and they are going to be visibly by both the forces of the market, but also by quality checks elsewhere, to manage what is going on with those patients. So if those patients need stuff that now they can't get to, somebody has to go to the emergency room, that happens to primary care doctors' office. They don't bill claims. There's no insurance. There's no nothing. They're looking after those 600 patients who are essentially a member of that concierge practice. And everybody in America now gets that level of concierge primary care. It will cost us about double what we spend on primary care now. And if you just look at the numbers of how those practices work, we'll save more than that on reduced spending in hospitals, emergency room visits, inpatient admissions, unnecessary surgery. Right. Now, this will obviously cause two massive seizures. We have to get there, and then we have to figure out what do we do with the downstream people who are currently profiting. So that is going to be tough love from me. We apparently like dictators now in America. So make me the dictator of health and human services. I won't be doing crazy shit about vaccines. I'll be encouraging more use of vaccines. But what I think we spent more money on public health, blah, blah, blah. But what we have to do is get the people who run hospitals in America, health systems, around the table and say, your life is changing. You're no longer building these massive feeder systems to your medical palaces. Instead, you are going to figure out how do you provide the really great cutting edge care, the best possible care. We are going to need specialists, we're going to need surgery, we're going to need advanced drugs, we're going to need oncology, we're going to need stuff. But you're just going to have less money to do it with, and we're going to reduce the amount of people who are coming in your doors because we'll have this great primary care instead. And you're no longer going to be like at the top of the food chain. You're going to be a partner. And I would suspect that many of these organizations in that kind of incentive structure, getting some kind of global budget, will figure out a way to partner with primary care, not buy them and squeeze them out of the process to where they are now, but be real partners.
So there's a layer of this also where we're moving into more, in certain pockets of healthcare, of a value-based care kind of model. What I'm hearing you talk about related to driving through primary care and focusing on keeping costs down seems to at least have some relationship to value-based care.
It's very close. Value-based care has been around, if you want to go back to 1937 when Kaiser Permanente started, it's been around a long time. It's always struggled to grow. And the main reason, I think, is that you are putting the pressure of having to manage global risk on medical groups and doctors who don't have the actuarial structure to set up for this. So now either as a primary care doctor, I have 8 people working for me, struggling to bill insurers, to fight with them about utilization management, to do all that administrative crap, which I am removing in the system. By the way, I'm also removing health insurance companies, you may notice. They don't play in this role. We don't need them. There are lots of parts within health insurance companies which will be around. There's a lot of IT which could be useful in the system. There's a lot of medical groups owned by health insurance companies that could play this role. But the actual insurance function is broken, stupid. We don't need it.
Right.
And then the other, but the other people, the value-based care ones, are now being given, okay, you're now at risk. You have to manage actually the contracts, the risk and stuff downstream. And that is too complex and that breaks it. I don't think you need to do that. I would trust American physicians, nurse practitioners, and their organizations to do the right thing, because I think they're here to do the right thing. And, you reward them very well and say, you are responsible for these 600 people. Wow. You're in charge of their health. And you went to medical school to make a difference. You're the smartest kid in your class. You could have gone to a banker. You could be a Bitcoin trader, but you wanted to be a doctor. I'm going to leave you alone. But there's no incentives for you to overbill, whatever. There's no incentives for fraud in the system. You get paid a salary. It's a good salary. Do the right thing. 98.7% of them will do the right thing. 99% of them do the right thing. And you don't need to do that managed care. And you sold the back end by having, I would have some kind of Fed Reserve type organization that was as wise men and women who would kind of manage how much we agree to spend on cancer care or whatever. You'd have to look at the price of drugs, some kind of European nice type cost effectiveness model for that. There's a bunch of questions into how you do this, but that's how you should set up the system, and that would fix excess cost, and that would improve care dramatically. And the care for most Americans would be so much better if we had a system like that. People who are in concierge care love it. Most Americans just could not pay $2,000 out of pocket for this stuff. And so, you've got to figure out a way to get there. Now, politically getting there is going to be a complete
right. Well, there's a big huge change and a mega trend that needs to follow this. But I do see promising areas of shifting the incentive and driving more through primary care. So it's a pleasure to hear your point of view. And hey, look, you've all heard it here. There are a couple of steps we can take leveraging primary care in order to better run our U.S. healthcare system. I really appreciate you sharing that, Matthew.
Yeah, thanks, buddy. I mean, I think the last thing I'd say is that I can't say I approve or appreciate it, but we have now seen evidence that if you take over the reins of government as a aggressive, executive leader, you can do radical changes. And why do the radical changes have to be the ones we're seeing now? Why can't they be ones good? We need a revolution. Yeah. Incremental change to healthcare, my entire career, in fact, frankly, the last 150 years we've shown doesn't work and has made stuff worse. And we have a bunch of people sitting in the middle getting fat and happy who really are adding precious little value. And I think so I'm now a fire, I'm a bomb throwing revolutionary. I encourage people to come to the healthcare blog, read more about this stuff. Go to the barricade.
Right, let's go. So, hey, check out the healthcare blog if you don't already follow it. And Matthew, it's a true pleasure hearing your perspective. I think there are way too many people complaining about the broken healthcare system and not enough people coming to the table with solutions. So
I
appreciate what you're doing. Well, let's keep the conversation going. Does that sound good?
Bradley, thank you so much. Really appreciate what you're doing here.
Very much. Yeah, thank you so much. All right. Well, hey, thanks everybody for being here with Matthew Holt, an absolute legend in the space. Appreciate you being here and sharing your point of view. We'll look forward to seeing you next time.